Good evening, ladies and gentlemen, or good afternoon, depending on what time zone you're connecting from. And welcome to today's cardiac MRI awareness webinar. We're delighted to have you join us this evening. My name is Dr. Chinedum Anosike. I'm a consultant radiologist. And I work partly for the NHS and also work as a director of Accuread Radiology, which is a teleradiology company delivering subspecialty radiology services to centers in Nigeria. I'm stepping in as the moderator for Dr. Adeleke, who couldn't be with us today. This webinar has been organized by Accuread Radiology and CMR. So CMR stands for Consortium for the Advancement of MRI Research and Education in Africa. CMR is a global network of diagnostic imaging experts working collaboratively to advance imaging across Africa and other low to middle income countries. CMR's mission is to train and mentor an interdisciplinary team of African experts to optimize their imaging infrastructure and also improve local access to high-value diagnostic imaging. So this webinar is generally at the core of the mission of CMR. So today's webinar is aimed at increasing the awareness of cardiovascular MRI amongst cardiologists to improve access, hopefully. The webinar is part of a series of interventions on CMR's part to improve local access, and comes on the heels of the dedicated radiographer training in cardiovascular MRI that has been ongoing in Nigeria and also some other low to middle income countries in the last couple of weeks. We've been working with centers such as Accuread Multi-Specialist Hospital in Lagos, Nigeria, to upskill their radiographers to be able to perform cardiovascular MRI. Therefore, a lot of the work has been done to upskill them and making it possible for you to be able to refer to some of these centers for your CMR requests. Here's a brief illustration of Katrina who is from Professor Friedrich's lab. She was in Lagos a couple of weeks ago to implement quite a few CMR techniques in Accuread Hospital, and it worked out very nicely because a lot of the radiographers were upskilled from that and would be able to provide CMR services according to best practice and international standard. So our speaker today, it's an honor to have with us today Professor Matthias Friedrich, who is our speaker today. Professor Friedrich is the Chief of Cardiovascular Imaging at the Division of Cardiology at the McGill University in Canada, and the Scientific Director of the Couture Cardiovascular Signature Program at the McGill University Healthcare Center. Professor Friedrich earned his MD at the Friedrich Alexander University, Erlangen, Germany, and completed his training as an internist and cardiologist at the Charité University at Humboldt University in Berlin. Professor Friedrich is a world-renowned expert in cardiovascular MRI and has authored and co-authored over 200 peer-reviewed publications on cardiovascular MRI. He was also the former president of the Society for Cardiovascular MRI. So his research focuses on new approaches for diagnosing cardiovascular disease using cardiovascular MRI, with a special interest in novel diagnostic approaches to visualize heart disease. Currently, his team is working on simultaneous multi-parametric acquisition and reconstruction techniques or SMART, cardiovascular MRI, oxygenation sensitive cardiovascular MRI, and the diagnostic utility of breathing maneuvers in diagnosing coronary vascular diseases. So it's indeed an honor to have Professor Friedrich speak to us today about this new or this exciting area of cardiovascular MRI. And it's my belief that you will come out from this talk well informed on the utility of cardiovascular MRI. As part of housekeeping, questions for Professor Friedrich can be typed in the Q&A box or in the chat, or we will take these questions up at the end of the presentation. Can I also ask you to kindly keep yourself muted for the duration of the presentation? Thank you very much. I'll now hand over to Professor Friedrich.
Thank you very much, and also thank you very much for organizing this event and inviting me to present. It is a pleasure for me. What I will do over the next time is to talk about cardiac MRI, why it has a certain role and potential in cardiology. And I will also give some outlook on some of the research that we're currently doing to give you all an idea of where this might be going. So first, I want to disclose that I'm also involved in software development, software that is related to the evaluation of cardiac MR images. But I will let you know if this affects my talk, but I'm not intending to do any advertisements here. So we have basically 4 imaging modalities in cardiology: echocardiography, nuclear imaging, CT, and CMR. And as you can see here, each of those has certain strengths and weaknesses. So there is no single modality that could do it all. However, cardiac MR is almost as good as any other modality in almost everything. And it's only surpassed by CT in terms of morphology, because morphology has so CT has a higher spatial resolution, but CT is slower in the image acquisition itself and does not have information on flow or tissue characteristics, are more difficult to assess, and doesn't offer anything on metabolism. Nuclear imaging is great when it comes to metabolism. However, has little else to offer. So that's why I personally think the nuclear cardiology is on its way out, largely replaced by novel CMR techniques. Now, echocardiography certainly is the workhorse and should be like that because it's the most time efficient, especially in emergency situations, and gives good information on morphology and function, but has also less to offer when it comes to tissue characteristics or metabolism. So when we look at the qualities an ideal imaging modality should have, it should, in the future modalities, should move away from these current limitations that they are invasive. Some of them are invasive, like invasive coronary angiography, or they use radiation like CT or nuclear medicine, radioactivity, use contrast agents as pretty much any imaging modality these days uses, and looks at surrogate markers only and not true biomarkers. So it should be less invasive, less or no radiation, less or no contrast agent, and look at actual biomarkers. But even then, such a technique should not only be accurate and precise, so robust and reproducible, but should have a prognostic value, should be cost efficient. And even if that is all fulfilled, it still doesn't help. It's still not a suitable imaging modality if it doesn't eventually has a positive impact on outcomes. So if the use of this imaging modality does not improve patients' lives in terms of quality or longevity, then it is useless, whatever nice images are produced. So I will very quickly go through the other imaging modalities as a background. So echocardiography is most widely available, has the largest number of systems around. It's relatively fast, although I don't think that counts as much anymore, because CTs and MRs are now faster, at least definitely CTs and MRs typically can be done faster. It is also considered relatively easy because you can do it on the bedside, and it's a manual operation with a device. And now we have mobile echo solutions even attached to the iPhone. But easy is a difficult word in this context because you need to be a very good, a well-trained echocardiographer to provide informative images. And that is sometimes a big problem. It's great to look at function and also other things such as pericardial effusion, and especially in emergency situations. And it is used as a standard for valves and function. However, the accuracy in some of these assessments is limited, especially when it comes to flow quantification and some functional parameters. It's relatively inexpensive. And the limitations, on top of what I already mentioned, we have an inconsistent field of view, inconsistent image quality, and you need to also have an expertise to interpret these images. There is an option for automation and artificial intelligence, but it's very limited. And the reason I'm mentioning that is artificial intelligence is now infiltrating pretty much any area of medicine, and especially areas where you have technology involved. So there are also attempts to use artificial intelligence to analyze echocardiography images, but it's much more difficult because it's all standardized. So nuclear cardiology, I do not actually want to spend too much time. It's widely available, especially in the US. It is used for ischemia or perfusion imaging and viability. It can be standardized. In fact, there's software that pretty much does it automatically, but it has a very low spatial and temporal resolution. It's using radioactive tracers. The quantification of volumes is highly inaccurate, and it has a low value outside of these applications. It's also very expensive. And while it has options for automation and artificial intelligence, as I said, I think this is a method that should have been gone years ago. It will eventually go away, except for some very specific applications using PET. But outside that, the utility in cardiology should be considered as very limited. Now, cardiac CT has had a very, let's say, a strong increase of its applications in Europe and in North America, mainly as a tool for non-invasive coronary artery angiography, and especially for ruling out coronary artery stenosis. There are other applications that are still in development, and the CT technology has been improving significantly. Most recently, so-called photon counting CT, which all increases spatial resolution and also the contrast between different tissues. So there's a potential for looking at the total plaque burden in the coronary arteries as a strong risk marker. And so this is currently a thing, to say it like that, in North America and the United and in Europe. And I consider plaque burden indeed a very strong prognostic marker. But we have to be aware that CT is a niche technology. It is for coronary artery angiography and maybe plaque characterization, but not much else. So one could say, okay, that's a lot because coronary angiography is so important for decision making. I would argue that. I don't think that coronary angiography is that important, but I come back to that later. But maybe the major limitation of CT, as well as, of course, invasive coronary angiography, is this one. Now here you have three people, and if you look very carefully, you see that the coronary angiographer has less hair on the lower parts of his legs. And this is caused by the radiation that the radiographer is, or the angiographer is exposed to. So it is a risk for doctors, but also for patients. And in fact, if you look at the effective dose This is now already 10 years ago, but except for some CT techniques, not much has changed. You see that you have in millisievert, you have, even with the CT, you are now between 5 and 10 millisieverts, and even a calcium score comes with 2 millisieverts. And then the dose applied to nuclear techniques is also relatively high. So this is a problem. And one could say, okay, it is not that much. Why? But there are several important reports out there that the exposure to radiation is significantly associated with various diseases, but also with cancer. And this is maybe the most important study. It's a population-wide study performed in Australia in 680,000 people. And they could find that, or they showed that even one single CT increases the relative risk. So it's not the absolute risk, but the relative risk by 20% to encounter cancer in the following years. With 2 and 3 TCTs is higher, so it's a dose-dependent complication. And this referred to pretty much all the, or almost all the cancers, so brain cancer, bone cancer, chest cancers, extremities. And if you look at the abdomen, spine, neck, so there is a proven risk of CT even at lower doses, and there is even for nuclear medicine there is even a study on the perfusion, on myocardial perfusion scans, and in this study it has been estimated that up to between 3,000 and 14,000 or 13,700 cancer cases per year may be due to myocardial perfusion scans. So that's why I think nuclear cardiology has to go, because we have better alternatives out there. So that brings me now finally to cardiovascular MR. And I want to just right off the bat start with something which I consider one of the takeaway messages I would want to leave with you. There are some unique contributions of cardiovascular MR, so contributions that cannot be done, at least not in that quality, by any other modality. And I have been a cardiologist in the cath lab. I have directed an echocardiography lab. I worked with nuclear medicine. So, and I have also, let's say, privileges for CT in our institution. So it's not that I'm, let's say, biased more than just my experience with MR. So MR is the gold standard for quantitative assessment of the heart, morphology, mass, function, and flow. Tissue characterization, and I'll come back to that later, is probably the single most important. We do not have any other imaging modality that gives us that clear and high resolution information on necrosis, scar, infiltration, edema, or iron accumulation. Quantitative flow and now also quantitative perfusion is also gold standard level. And there are some new techniques out there, of which some were initially mentioned by Dr. Anosike. I'll briefly only mention a few of them and get a bit more deeper in the oxygenation-sensitive MR. Now, I don't want to bore you with physics, but it's important to understand that magnetic resonance imaging generates a contrast differently from all the other techniques, because in other techniques, such as CT, where we beam a high energy signal through the body and look what happens elsewhere, what happens on the other side, how much of that gets through, which is a pretty brutal thing if you think about it. Or ultrasound, where you beam a lower frequency and wait for the tissue to send it back. So we're talking about 7 megahertz with ultrasound, 4 to 7 megahertz. In MR, we use a different principle. In a magnetic field, all the protons align themselves with the vector, with their average vector, with the magnetic field, with the vector of the magnetic field. But they are not just standing still there, but they perform a certain movement, which is quite interesting because it's part, basically, if you will, of the quantum mechanical world. So they have their axis stays still in the middle, and they perform almost a rotational, but it's not a rotation. It's a movement which is called precession. And this precession happens with a frequency that is related to the strength of the magnetic field around it. So if you have an MR machine with 1.5 Tesla, which is a typical field strength for clinical application, this happens with a frequency of 64 megahertz, which is relatively high, but it's not very high. So in fact, it is not sufficient to alter the molecular level so that electrons could be kicked out of atoms. Why is that important? If you kick out electrons from molecules, you can actually change molecules. So this means you can break DNA. If you can break DNA, then you increase the likelihood of, let's say, an insufficient repair. While we have all DNA breaks over the day, in fact, more than 25,000 in our body every day, if you increase that by a high energy beam, then you increase the risk for cancer. So the MRI at 1.5 Tesla operates at 64 megahertz. That's still less than probably your favorite radio station, which may operate at 90 or 100 megahertz. So this is an energy, a frequency that is not harmful. As opposed to that, CT operates in the gigahertz, so it's a factor 1,000 times stronger. So what does MRI, the MR experiment, do? So if you beam in a pulse of 64 megahertz, the vector of the protons is tilted out, and also this precession all of a sudden gets into a synchronicity. So they precess in sync. And then if you stop that pulse, everything goes back to the previous. So the vector aligns itself against the magnetic field, and the precession loses its synchronicity. And these two actions, the relaxation or the bouncing back of the vector and the loss of coherence of the phase, this can be measured or estimated, but the time, how long it takes, depends on the molecular environment. So in short, if I measure the time of the bouncing back of the vector, then, and it's not the entire time, but 63% of that, that is the T1. And whereas the loss of coherence, that's T2. So a tissue with a long T1 will behave different from a tissue with a short T1. Now, for example, if you have a watery tissue, edema, or you have the bladder, then the water has a much longer T1. The water will behave totally differently from adjacent organs that do not have as much water. On the opposite end of the spectrum is fat. Fat is very fast. So one can memorize that: fast food, fast fatty food. So fat has a short T1 and a short T2. Whereas water, think of long drinks, water has long T1 and T2. And all the other molecular environments in the body have their typical T1 or T2. So we know, for example, for myocardium, the T1 of T2, the typical ranges, we know, so this gives us a different information. And the initial studies by Damadian et al., they used actually this to characterize tumors, which is now still being explored and used. So in summary, the basic principle of MR is to use the magnetic property of protons in molecules. Protons, so H1, are abundant in the body, and since the signal that we get is reflective of the molecular environment, we basically have a signal that comes right out of the tissue. So we do not need to beam a hard beam through the body or wait for an echo to come back, but we can see the relaxation of the system, because it emits a very small amount of energy, and we can measure that with an antenna called coil. Okay, so much about the physics, and it's not a problem if you don't know the details, just that you know that it works with beaming in high frequency pulse that is not dangerous to molecules and atoms, and it leads to an excitation of the system, and the relaxation of the system is something I can observe and then conclude which tissues it comes from and where it comes from. So the advantages of CMR is it's a safe technique because you do not have the radiation. It's generally non-invasive, and the contrast agents, even if you use a contrast agent, are very well tolerated. It has a high spatial resolution, albeit not as high as CT, but close. It has a very consistent image quality. The quantitative data are accurate and reproducible. There's a relatively small observer dependence because the images are generally self-explaining. Very important, they have an excellent tissue contrast, and they have an access to the molecular level. In fact, we cannot do anything else than imaging molecules. So that offers also for the future with machine learning very important opportunities. And then as the final and maybe most important advantage, this is one technique that allows you to assess a lot of things at the same time: morphology, function, flow, vessel lumen, tissue composition, and metabolism. And here's a typical two-chamber view of a heart. This is not using any contrast agents. So you see the left atrium, the left ventricle, you see the mitral valve, you see the coronary sinus, you see pericardial and epicardial fat around the heart. You can also see some trabecular muscle bundles here. You see part of the papillary muscle. You see parts of the left atrial auricle. So you can also see the flowing blood. So there's a lot of information in this image. When I started with MR, it actually took about 7-8 minutes for such a scan. And now you can get 3 of them in a single breath hold. So it has become very fast. And here's a typical so-called black blood image showing the anatomic accuracy here. The myocardium, you see the moderator band here, you see right coronary artery here surrounded by fat. And one could say, hey, maybe this is just one of the fancy new machines. No, this picture is actually has actually been taken in 1998. So this is 25 years old, and I'm 100% sure that all the scanners that you have access to can do this or even better. So there are lots of applications of CMR, with not only morphology and function with the cine images, but also perfusion imaging, and I'll come back to that, flow quantification for valvular disease, angiography, and then, as I mentioned before, very important tissue characterization. So just to repeat, tissue characterization, quantitative imaging, and some new techniques are highlights for MR. There are also some challenges. We have the heart is continuously moving, so we have to typically trigger the scanning by an ECG. So that is, there are also free breathing methods out there, but most of the time we use an ECG triggered. So you need to put an ECG electrodes on there. Then we deal with breathing motion, and of course motion blurs images. So that's why typically breath holds are required. We need to have someone who is able to find the anatomical axis of the heart. So this is something quite individual, although the new machines now have automated algorithms that do that themselves, and machine learning will improve that significantly. You ideally have flexible protocols, which means that you're not always like in the brain or so, where you have your T1 and your T2 flare and whatever standards you're using. No, here for a valvular disease or for iron overload or for sarcoidosis, you may have different protocols. So there are ways to standardize that as well, but this is definitely something to consider. Now, formally, it was always said that pacemakers cannot go into MR. This has always been, I think, overstated. We are scanning pretty much all pacemakers and did not have any problems ever. Legally, it is that the manufacturers of pacemakers, they say, yeah, don't do that. And there have been some theoretical considerations, but there are lots of papers now out there and thousands of patients who have been scanned with pacemakers and defibrillators, and it is safe. What we do, we ask electrophysiologists to check the pacemaker before and after the scan. And before the scan, ideally, the pacemaker is put into a default mode. Or if patients are not pacemaker dependent, it's just switched off during that time. So this is not a significant limitation anymore. And then also, as a limitation, heart failure patients may not be able to lie flat, and that's the same for a cath lab or for a CT scan. So in some patients, this is a problem, but with shorter protocols, it is also mostly achievable. So we do quite a lot of patients with heart failure. Okay, image quality. Image quality is, that's one good thing, is typically very good. This is data from Calgary, 6,500 patients, and only 1% of them had a poor, which means non-diagnostic image quality. So that's very important for the efficiency of a scan, that you have a consistent image quality. The sequences that are used for clinical CMR, so for those of you who do not do MRI, that may not tell you a lot. So next to the localizers, there are black blood sequences, T1 weighted. There's for tumors, for example, there's pre and post gadolinium FATSAT T1. Then there are cine images, depending on which vendor you have. With Siemens, it's the TrueFisp. Philips is Balanced FFE, and with GE, it's Fiesta. Then you have black blood T2, which is especially important for edema. Then so-called late enhancement for scarring, angiography, flow-sensitive images, T2 star for iron and hemorrhage, first pass perfusion, and then T1 maps and T2 maps. So this is something that has come up over the recent years. It still causes a little bit of problems. So mapping is not there yet, but it certainly has a role for some diseases. Okay, so what are we using this for? So for anatomy and function, I already mentioned the cine images. We take a long axis view, place a short axis stack, and then this is, by the way, a stack that has been acquired in 3 breath holds. So then you have a short axis view of the entire heart. You see mitral valve opening, for example. You see parts of the aortic valve. You see the papillary muscles. You can look at the fat around it. So this is not a particularly good image quality. This is, I think the images I saw from Lagos were better than this one, for sure. So then, as mentioned before, you can use a short axis view to then place several long axis views. And here's a case where you have some pericardial effusion around it. You can see the mitral valve, and you can see that there's a pronounced trabeculation in the heart. And so there's a lot of detail. And I very much like long axis views because they allow you to quantify the volumes while you see the mitral valve and can basically precisely define that. So newer, let's say newer approaches also include strain imaging. So you can look at the regular images, but with some software, you can also extract strain information from these images. And this is how it looks like. And what I like about strain imaging is, if you use color maps for that, you do not need to be an expert to see that here during systole, this part behaves differently, whereas this is normal. So the color code shows you the strain and shows exactly that in this patient with a stress-induced cardiomyopathy, that the apex blue would mean dyskinesis, yellow is borderline but pathologic borderline, and red is normal. So strain imaging will help so that even non-experts can easily identify regional or global wall motion abnormalities. So in valvular heart disease, you can use these cine images to, for example, look at the opening of the aortic valve. The aortic valve area, the orifice area, is a very important marker for making therapeutic decisions on surgery or not. Here you can see the calcification here at the valve. And then you can also, during the same scan, quantify the flow velocity. So you can basically measure pressure gradients, and you can also perform a planimetry. In this case, severe aortic valve stenosis. So these are relatively simple and reproducible ways, and you can have several of that. So you can quantify the flow, you can measure the area, and in the same scan, you get the left ventricular function. So this is very informative. So while this is here aortic valve stenosis, there's also a strong argument for using MR for mitral valve insufficiency, because you can look at the stroke volume and you can measure the flow in the aorta, and then you just do the math, and then you know how much of the blood actually went backwards into the left atrium. So in valvular disease, although echo is often used, in case the echo doesn't match the clinical expectation or the image quality has not been good, definitely MR is a very strong added value. So tissue characterization. The most frequent application these days is myocarditis. So in myocarditis, you can either use mapping or you use T2 weighted images, so edema sensitive images, and late enhancement, so post-contrast images, to look at the two markers, one for edema, that is mainly T2-based imaging or T2 mapping, and the other one is looking at the injury depending on T1. So this is a T1 criterion, this is a T2 criterion. These are the two criteria, and then there are supportive criteria looking at pericardial involvement and LV dysfunction. So these so-called Lake Louise criteria have been used also in COVID-19, and there are recommendations out there in these diseases, especially in myocarditis associated with acute disease. And I just reviewed today a paper for a very important cardiology journal. They could show that edema, which is a frequent aspect in COVID, in patients with persisting symptoms, they found that more than 90% of patients with persisting symptoms after COVID had myocardial edema. So this is one of the outcomes. If you do not recover fully, then myocardial edema may persist, as we also published here during the COVID pandemic. So this helped a lot in the understanding. So we are, in the future, it will also be possible to get rid of the contrast agent here. So these are some data we are currently putting together for publication, so that just based on the mapping, you can regenerate the necrosis images. So I'm going to skip that here. Here's an example of the classical methods. So this is the same patient. On the left side is a T2 weighted image. On the right side is a T1 weighted image after contrast injection. And what you can see that there is a scar here. The bright area means scar, dark means normal. And you see that compared with this, there is a higher signal intensity in the edema-sensitive images that is larger than the actual scar. Here's the computer-aided evaluation, which just means that in this case of a reperfused myocardial infarction, the initial injury that affected the entire myocardium was much larger than the final scar, and simply because there was a reperfusion that was early enough. So what does that say? MR has a high sensitivity to detect myocardial edema in any even reversible injury. And with contrast enhancement, so-called late enhancement image, you can also then see the irreversible injury. Now in myocarditis, this may play a role in the acute detection of myocardial edema. and then assessing for the recovery. And in patients with persisting symptoms, this could be perfusion, could be ongoing perimyocarditis or myocarditis, or could, as I just mentioned before, be just chronic edema, which is also a problem because edema over time can lead to interstitial fibrosis, and then maybe even to a heart failure with preserved ejection fraction. Here again, an example in myocarditis, in acute injury. Here's a healthy subject with a water-sensitive image, so T2 weighted. Here, reperfused myocardial infarction involving even parts of the right ventricle. And then here, a case of acute myocarditis where the signal intensity is overall increased. We quantify that, or we used to quantify that in relation to skeletal muscle as one marker for quantified marker for myocarditis in the first set of the Lake-Lewis criteria. Now the updated sets, they include now mapping, but the first set, of course, can still be used. And this is just to highlight how specific the edema is for acute disease. So if you have edema, there's a 90% specificity that this edema reflects acute disease. Here's an example of with the same patient, acute, and then 3 months after myocardial infarction, you see the edema in that territory, which completely disappeared. Here you see the small infarction. The infarct also shrunk, but that's normal that initially with the swelling, the infarct size is overestimated and then only eventually reaches the real size. The regional distribution of injury, now I'm talking about late enhancement, it gives very strong diagnostic clues. That's why late enhancement imaging, so contrast agent enhanced imaging is important. What late enhancement refers to is that you inject the contrast and then you wait for about 10, 20, or up to 30 minutes. Usually the gadolinium is washed out of the normal myocardium. But if you have a scar or if you have necrosis, then the gadolinium sticks in the myocardium. So wherever you have gadolinium still in there, it means that there is an abnormal expansion of the extracellular volume, which is typically caused by fibrosis or necrosis. So scars do that. And the important fact is that when you have an ischemic scar, which means myocardial infarction, these always involve the subendocardial layer, as you can see here. So the inner layer, or here the papillary muscle. Whereas in myocarditis, it's never or almost never the subendocardial layer. It's always more in the middle or on the outside, so subepicardial. And this allows us, looking at the regional distribution, to separate ischemic from non-ischemic acute injury. Or this could also be chronic, so scarring. For myocarditis, it's important to realize that you can have edema only without having associated scarring. So the late enhancement image can be negative, no scar, no necrosis, but there could be edema. So the tissue characterization here allows us to assess for acute or chronic, because we can differentiate acute with edema from chronic, no edema, but also reversible or irreversible. Because if there is edema, but no late enhancement, which means no scar, then there's a high chance that this will recover. If you have both edema and necrosis, it is less likely to recover. Now, this is important information. Here's an example of a patient, a young patient who presented with acute symptoms, and the echo was normal. And we can also say that overall, the left ventricular function, the 2-chamber view, 3-chamber view, and a short axis view looks normal. So there is nothing really very remarkable. However, if you look very carefully, you see that this area here, that's inferolateral, does not work as well as it should. But the rest looks very good. So one could say, hey, there cannot be a lot of myocarditis because the function is good. But no, here you can see that there are several areas with necrosis. You see here a subepicardial, then distributed in the myocardium. So this is severe necrotizing myocarditis with normal left ventricular function. So in fact, most of the patients with acute myocarditis have a normal left ventricular function. So this is important to keep in mind. As I said, mapping has entered myocarditis, but I'm not going to comment too much on that. Mapping is directly estimating the time, the T1 and T2 time, instead of looking at signal intensities. So this, the promise of mapping was that you have basically a number and are not reliant on visual assessment. However, mapping has some issues with standardization, variance between different scanners, between different field strengths, and also image quality issues. So it is still not used everywhere. However, when used properly, it has a very high accuracy. And just recent data have confirmed that. And the only trial in myocarditis that has been performed since many years was actually did not use biopsy anymore, but really only MR. And so this is also why, because you do not need contrast agents for mapping, you can also run this without contrast agents. So having mapping technologies on the scanner is beneficial because you can save a lot of money on contrast agents. MRI has been compared with biopsy result, and the accuracy of the Lake-Lewis criteria is very high, 91%. And I think it's even probably better than that, because I don't think that endocardial biopsy in the first place is very accurate. But here a very recent paper also showed that if you have complicated presentation, and that's the only reason to perform a biopsy. So if you have a complicated, which means with heart failure, arrhythmia, or severe, otherwise severe complicated course, the accuracy is actually 100%. So we really do not need biopsy anymore when we have access to a CMR scanner. So CMR has also shown to be predictive in myocarditis. So I'll just have to speed up a little bit. And recently it has been also shown, if you combine this then with ECG and other clinical markers, you can increase your accuracy further. So perfusion. Perfusion is, here's an example. You give a contrast agent into the vein, and then here you can see there's a perfusion deficit. That has been developed already many decades ago. And in the meantime, it has been shown to be very accurate, and also is as good for making clinical decision as an FFR done in the cath lab for estimating the severity of coronary artery stenosis. So this is a paper in the New England Journal. And this paper is now in press. This will be published during the next weeks. A comparison in a large trial with 600 people between SPECT and CMR, and SPECT hardly ever touches the diagnostic accuracy of CMR. The perfect test would be here. This is just tossing a coin, and you see SPECT is not bad, but CMR supersedes it. And this was very obvious. We now have also automated methods to have an automated evaluation, and also a quantitative analysis. So it is important to realize that we need these tests only if you have a patient, and this is from the European guidelines, we have a relatively high pretest likelihood. So if you have no pretest likelihood, so is a young patient, atypical chest pain, there is no need for any test. If you have a patient, a typical patient, obese, 55 to 70 years old or known coronary arteries, you don't need a test either, because it's pretty clear. The pretest likelihood is very high. Only in between. And the European guidelines and the American guidelines have now come up with something very similar. If you have a rather low risk, then a coronary CT is probably the better option. But if you have some risk at least, then this is where techniques come in, and CMR is one of them. So I'll skip that here. So the last thing I wanted to talk about is oxygenation-sensitive magnetic resonance imaging. And what it does is, this is a technique where the signal intensity depends on the oxygenation of hemoglobin. So a tissue that is perfused by blood or supplied by blood with a high oxygenation level will have a higher signal intensity than tissue with more deoxygenated hemoglobin, to have a lower signal intensity. So the blood, for example, in these images in the right ventricle looks darker than the blood in the left ventricle. Now, what we have added to that is, and we have worked on that technology since now almost 25 years, but then we have developed something else that also doesn't need adenosine or any other vasodilator. It's just using breathing. And why does that work? Because with normal breathing and a normal vascular tone, everything is relatively stable. But if you hyperventilate, and what we use is 1 minute of just deep breathing, these are typically 30 deep breaths, the brain and the heart go into vasoconstriction. And so there's a net reduction of blood flow and blood volume. And with that, there is also a reduction of the tissue oxygenation. And we can see that with the oxygenation-sensitive images. And then if you have a breath hold, you have an overshoot, and you go into vasodilation. And this response here to these maneuvers, this depends on vascular function. So we have a measure for vascular function. So again, this is dependent on the so-called bold effect. So deoxygenated hemoglobin comes with a lower signal intensity in MR techniques that are sensitive to this effect. And when we applied adenosine, we could see that and compared with the fractional flow reserve, we could actually differentiate patients with significant coronary artery stenosis from those without, just based on the response to adenosine. So there was not associated with the breathing. But then we did that with breathing, and this is just one of the scans, one of the studies that have been published by several centers now. So we have done probably most of them, but there are studies here. This one is from Bern in Switzerland. There's studies from Boston, from the UK, from the US, and from China, confirming that if you use this technique and track the signal intensity over time, or the response of the signal intensity, compared to a remote territory, a coronary territory with coronary artery stenosis, cannot increase during the breath hold, cannot increase the blood supply, therefore cannot increase oxygenation. And this has a high diagnostic accuracy. And we have now partially completed an international multi-center trial that could show that this accurately identifies a significant coronary artery stenosis. And we have also applied this to patients with ischemia and microvascular dysfunction. We have applied this to heart failure, and we have now formed a special interest group, and more than 20 centers worldwide have started using this technology now, and we're eagerly awaiting their research. So with that, I wanted to stop and give some time for questions and answers, and feel free to send any questions. Also, we have on Friday, for those who are interested in Friday, this Friday, we have a webinar, free webinar on oxygenation sensitive MR imaging with breathing enhancement, where some of the new results will be discussed. So if there's interest, then I'm certainly happy to share that. But you can also find this on the internet, oxygenation sensitive MR, McGill at Montreal, you should find it. Thank you very much.
Thank you very much for the wonderful talk, Professor Friedrich. You've managed to cover quite a lot within 45 minutes, and we're very grateful to you for taking the time to do this. Can I encourage the participants to please type in any questions that you have on the Q&A or on the chat, and Professor Friedrich will be able to see them and answer them. Professor Friedrich, I think there's a couple of questions already in the chat.
Yeah, I have already seen two of them. I sort of addressed some of them. So T1 and T2 mapping are indeed in use. So we are using that, and pretty much all large cardiac MR facilities do that. However, as I said, there are some issues with standardizing the results and with the consistency of the image quality, and therefore of the mapping. So it is not easy to get in there, but T1 mapping and T2 mapping have certain important roles in some diseases. And those are primarily if you have Fabry's disease, which is a lipid storage disorder, in patients with LV hypertrophy. There it is very good, better than anything else I could imagine. T1 mapping is also good in visualizing iron overload in patients with thalassemia and frequent blood replacement. So this is very important because in the UK, the use of MR for assessing the iron overload in the heart has changed how people are treated, because they are not treated for their liver iron, but they are treated for their cardiac iron. And the cardiac iron is actually the iron that is prognostically important. So since they've done that, the mortality of thalassemia has dropped by 80% in the UK. So this is extremely powerful. And then also in diseases like amyloidosis, that comes with a very high T1. This is also possible in myocarditis and acute myocardial infarction as well. So I think mapping has a certain role, but it's not just something you can just start like that. It requires, it has a learning curve, and it requires some time to be performed then properly. Okay, then the other, with the myocarditis to be normal in echo and have positive findings, I think I showed an example. It is actually typical that echo looks pretty normal. Patients have significant symptoms, and then you do an MR and see overt myocarditis, especially in young men. It's not a disease of elderly, and it's also not a disease of, I have hardly ever seen women older than 30 years old or postmenopausal with myocarditis, with viral myocarditis, but the typical is the typical male between 17 and 25 years of age. These are the ones with normal echo and necrosis. So yeah, I think that those were the questions that I saw in the chat. Any others?
Well, I think there's a hand that was raised as well.
Okay.
Have a look. Someone had a raised hand. I don't know if they'll be unmuted to speak.
I see yeah.
I am Dr. Accuread Radiology Ltd, cardiologist from Morocco. I thank you for excellent presentation. You listen me?
Yeah.
Okay. I would like to have two questions. The first for CT radiation. Currently, with the new generation machines, we have an irradiation less than 1 millisievert. What do you think about? And the second question for cardiac MRI, during myocarditis, when we find just edema and the T2 and elevation T1 and T2 mapping, but we don't have light enhancement. Can can return the diagnostic of myocarditis or no?
Yeah, so these are good points. So as I said, the CT technology is evolving, and it is just that while it is always said that it's less than one millisievert, the actual data, when you measure the applied radiation and the millisieverts that are actually exposing that the patients are exposed to, they're typically higher. But even if it's just 1 millisievert, even just half a millisievert, you have to ask yourself, if you get the diagnostic information elsewhere with the same accuracy or even better, then even that is not something you would want to do. So it's the same with a car. When your brakes are not okay, it's better to repair them, although nothing may happen. But just in case bad things happen, then it's better to have the full. So that's why I'm especially cautious in young women. Or younger women, because they are exposed to a higher risk of breast cancer with that. But I agree, it's nothing to be panicking about. I just think in general, we should consider, if we get that information that we need, for example, CT, coronary CT angio, this is great for getting people out of the emergency room if they have suspected coronary artery disease. But if you're, for example, for therapeutic planning, it's not that good. So a perfusion scan it gives you a much better idea whether this needs to be treated or not than just looking at the stenosis, because you can have stenosis, even almost complete blockage, and the perfusion is still okay because there are lots of collaterals, for example. So that's that. And then the other question with myocarditis, absolutely, you can have just edema and no late enhancement, and patients can have symptomatic myocarditis. These are typically more benign cases, but we have seen, especially during COVID, we have seen quite a lot of that. So patients who had no or very little late enhancement, or sometimes only in the pericardium, but had edema in the myocardium and had symptoms and sometimes also other ECG change, for example. Edema often in the ECG is visible as an ST segment change or a T inversion. So this is possible. It's not the norm, but it's definitely possible. And then there's another question for beginners in CMR. What are the sources that you advise to start with? Yeah, this is, of course, a big question. So first thing is you need to have the basic sequences, which I would consider the cine image, black blood T2, and late enhancement. So those are the three basic images. And if you can, then flow velocity encoded, that would be next important, and then mapping. So with these three standard sequences, you can already do a lot. I worked for 10 years just with these three sequences. So that's number one, which is sometimes called the cardiac package. Then number two is a coil that gives you a sufficiently high spatial resolution. That could be a thoracic coil or a surface coil. There are also cardiac coils out there, although a good surface coil, even when it's not called cardiac coil, could be used for that. It's just that it's important to keep it close to the heart. What helps a lot is you can also use the spine coil, and then put patients on their belly, and then get the heart close to a surface coil. So that's number two. And then number three, of course, you need to have a training of the tech how to do that. There are programs out there from the SCMR. There's also material on the internet. Ideally, of course, a tech has the chance to go somewhere for, let's say, 2 weeks or so, and to witness how this is done on a scanner they have themselves. And so that's number three. And number four is also important. You need to have software. And I have been involved, and I am still involved in software. The reason for that I was involved in there was because I saw that without having an efficient software, it's just too onerous to evaluate all that. You don't want to spend half an hour or an hour evaluating images. So that's why you need software that allows you to speed that up. so that the day is efficient. And there are several softwares out there, Circle, Neosoft, Pi Medical, Medis. So there are a couple of companies out there that sell software, that sell software, and they also provide, actually, at least some of them provide special discounts for low and middle income countries. So you should inquire on that. And the CMR has also an outreach program that helps countries to get started. So those would be my first answers to that.
I think there's one more.
Oh, is there some points where the CMR are limited compared to T? Oh, yes. MR is not very good at small, chaotically moving structures. So vegetations, don't do a CMR for vegetations because you will not see them properly. And TE, so just because of the vicinity of the findings, is also, I would think, better in characterizing the morphology of ASD and other congenital diseases that are close to the esophagus. So this is where I think a TE is clearly better than any other imaging modality. So endocarditis and atrial septal defects or congenital disease in that area, I think a good echocardiographer can do that better than a CMR scan.
Okay, I think we've probably exhausted the questions, and there are no hands raised. So thank you very much, Professor Friedrich, for taking the time to walk us through cardiovascular MRI. It's been a wonderful talk. I suspect that a few more people couldn't be here because there was a public holiday in Nigeria, where quite a lot of the registrants came from. But this is something we're hoping we would run again in a short time to keep the awareness going, especially now that there are a lot more 1.5 Tesla scanners in sub-Saharan Africa. There is a lot more potential that CMR techniques should become mainstream in practice in sub-Saharan Africa and in other low to middle-income countries. So the knowledge you've shared today is very, very useful for us to be able to introduce this to the clinician population. And I'm sure all the cardiologists on board here would agree with me that this has been a very wonderful evening listening to this talk. So I want to thank you very much for your time, and for all of you who attended. I also want to thank you for taking the time from your busy schedule to listen to the talk. There will be a slide shown at the end that will give you a few contact details where you may be able to keep in touch with the camera group, who will be, they're normally a very good resource for, some of the questions you've asked about beginners in CMR. Camera would be a very good resource for pointing you in the right direction to be able to start your CMR journey. I thank you once more for listening, and have a good evening.
Thank you. All the best to everybody. Bye-bye.